Evening, everyone. Thank you so much for joining us for our second installment of our series of webinars brought to you by the South West London lead provider Trauma and Orthopaedic and MSK network. My name's Bodine Pierce. I work as the clinical therapy lead at SWL, the elective orthopaedic centre based in Epsom, as well as one of the project leads on the Trauma and Orthopaedic and MSK lead provider network, which is hosted by Epsom and St Helier. And it's a really great opportunity for us all to come together as clinicians across Southwest London, whether you're working as a GP or a first contact practitioner or an advanced physiotherapy practitioner, and any clinician working within MSK, with the aim of achieving the best possible clinical practice and raising standards and quality of care for patients. And we can do this by standardizing pathways and minimizing unwarranted variations. So the aim of these training modules is about streamlining the referral process to be easier for and more user-friendly for clinicians, but also for patients by eliminating delays and duplication and ensuring that patients can get the right care at the right time. So what the session will aim to tell you is just create an awareness of what the red flags are and what sort of constitutes an urgent referral, what conservative management is expected prior to the referral, what a good referral looks like and what standards to include, what diagnostics should be provided or indeed not done within primary care, and sort of what the post-op pathway looks like. So we will be recording the webinar, so not to worry about recording this yourselves. We will also be enabling the questions in the chat function, so if you don't mind to ask your questions in the chat function, and then what we'll do is we will endeavour to answer all of those questions after the presentation. And we will also send you a feedback form in the coming days. So after we've received your feedback, we will also send you a certificate of attendance and a reflection sheet that can go towards your CPD. So if I might introduce Mr. Mark Webb, who's a consultant orthopaedic and trauma surgeon based at St George's University Hospital, as well as the South West London Elective Orthopaedic Centre. And his elective practice focuses on hip and knee joint preservation and sports surgery. And he also works in the major trauma centre managing patients with complex injuries. So if I can hand over to Mr. Webb.
Thank you very much, Bodine. So thank you everybody for joining this evening. I know it's just about to be Christmas and probably the day that we would be trying to drive and get to places, but we're all stuck where we are. So I've put on my Christmas jumper to try and bring in a little bit of spirit, and I may have a mulled wine if you see me having a little swig. So can we just confirm that you can see my screen?
Yep, we can see it.
Perfect. So here we go. Wonderful introduction. Thank you very much. So this is me, and this is where you can find me. Essentially, referrals going into St George's, I would see the patients there or at the Nelson Health Centre in Wimbledon. But I do all of my elective operating out of Swellyok, and I only do I mainly do just trauma at St George's. So I've been given the kind of the soft tissue hip, young adult hip talk to give this evening, and I kind of think of it as the hip when it's not arthritis, and there are plenty of people with very similar qualifications to myself that would call themselves a young adult hip surgeon, but I'm not quite sure what that means. Well, maybe I'm a sports hip surgeon, but again, I deal with people who don't play sports, so I must be a soft tissue hip surgeon. Well, but I see people and deal with things arthroscopically, and a lot of the time work on the bones. That doesn't really fit either. So this is a newer, I suppose, an evolving area of orthopedics, and we can't really make up our minds what the subspecialty is, let alone how to get the right people seen by the right people. So hopefully we can make a little bit of progress this evening, and very much want this to be interactive, and certainly get your questions in for the end to see if there are any suggestions on making the whole process a little bit easier for everybody and better for the patients. So I look at it as, well, what I do is I see people with pain in and around the hip that don't necessarily have established osteoarthritis. And we as a profession, as in orthopedic surgeons, are pretty bad at understanding why people's hips are painful unless they have osteoarthritis. And not even that, unless they have osteoarthritis bad enough that they think that they need to have a hip replacement. So hopefully we can touch on some of the ideas about why people may have pain from the hip when they don't have OA. So as already mentioned, we will just touch on the red flags and urgent referrals, which there aren't really that many of, particularly in this talk. Most of them will be covered in the other relevant talks. We'll try and understand why the hip can be painful. We'll talk about some investigations, why they're useful, why they're not useful, how to interpret them, and the difficulties, particularly in managing these people in the community with regards to the investigations and the interpretation of those investigations. We'll talk about some treatment options. Obviously with the skew that I'm a surgeon and love to operate, but I'm very aware that, that not everybody needs an operation. And when to refer. So this is about, you know, getting the right patients seen by the right people. And yeah, we'll touch on post-op management as well, as it's a kind of a newish evolving area, and we'll go on to the pathway. So in terms of urgent referrals, these are kind of three that spring to mind for me. So your septic arthritis, which you know, I'm sure will be covered in every other joint that is presented to you, and you know the red flags for that. So a patient that's unwell, reduced range of movement, pain, swelling, etc. And slipped upper femoral epiphysis is kind of one of the red flags for pediatrics. So I won't go into that too much, but it does. There is a crossover of patients that have subtle SUFIs that then present later in life with hip impingement and hip pain. But we will touch on stress fractures, as this is, well, particularly in the orthopedic teaching, is pretty poorly talked about, but is something that we see relatively commonly, particularly in the lead up to big events such as the London Marathon. And I wouldn't be surprised that when we start to come out of lockdown and people are realizing, like myself, that we've put on some serious amount of timber during this time, that people are going to get out and start doing more. And I wouldn't be surprised if we see quite a few people flaring up and getting stress fractures. So they classically present with anterior groin pain, worse with activity. Very much in the history, the vast majority of people will have something that has changed in terms of their training load. So they can be a really active person, but they've just changed perhaps the intensity of the training, the distance of the training, their impact in their training. So it's really important, and I'll probably repeat myself multiple times tonight. It's really important to listen to the patient, listen to their history, because the clues for the vast majority of what I see and deal with is in the history. Risk factors. So when I talk about risk factors, I mean in terms of nutritional status and bone health and the normal risk factors that you would see with people that have got reduced bone density. But again, in the sporting population, you're thinking about female athlete triad syndrome. So, you know, high output type patients that perhaps are amenorrheic and have early osteopenia or even osteoporosis. Saying that, they can happen in any group. But it is obviously more common. And early diagnosis, really the test is MRI, and that's what's going to give you your answer of whether there is a stress fracture or not. And that is what I think is what then enables the patient to rehabilitate appropriately. Obviously, it's a little bit more difficult to get. And I would suggest that if you see a patient with this and you are concerned that they've got a stress fracture, I think that should be a referral into the local fracture service. And if you don't get anywhere with then you know, someone like myself would be very happy to see these patients urgently. They should get an MRI, they should get an X-ray to rule out another cause or a significantly displaced fracture. But MRI is the thing that's going to give you the yay or nay of whether you can get them going non-operatively and just with some rest, or whether they need something else doing. So back to the hip and when it's not arthritis, there's a whole plethora of different reasons why the hip can be painful. But I'd say that the most common, or at least the most well-known, I suppose, is femoroacetabular impingement. And this is a long phrase, which means very different things to different people. And there's been various groups that have tried to come up with definitions. So there is the Warwick definition of femoroacetabular impingement syndrome. And they're all very useful. And, you know, I recommend kind of having an awareness of them, but I've never been very good at remembering a specific consensus agreement and the definitions of them. I'm a little bit more simple than that. So I just think of it as it's an abnormal contact between the femur and the acetabulum. And that doesn't necessarily mean that there is abnormal bony morphology. It may be that someone's doing an abnormal activity. And when I say abnormal activity, a sporting activity or a recreational activity such as martial arts or ballet or something where the hip is being put into funny positions. So you may have abnormal bony anatomy, or you may have an abnormal activity, which is very normal to many people, I appreciate. And they boil down into two groups. Like I said, I'll try and keep things as simple as possible so that I can remember them. Patients tend to either have too much movement or too little movement. And in the too little movement group, this is what we classically know as femoroacetabular impingement, where you have either a pincer lesion with over coverage of the femoral head. You have a cam lesion, which is excess bone at the femoral head-neck junction, or you have combined with both. And the idea is, as your hip goes through a range of movement, that these bony abnormalities impinge on the soft tissues and then can cause damage inside the joint. And conceptually, this can be a little bit difficult to get your head around, particularly with our trainees and some students. So I made a fairly budget animation that we'll go through in a minute. So on the flip side, so with too little movement, you then got too much movement. And as I've already mentioned, it can be in inverted commas, an abnormal activity. So martial arts, particularly Taekwondo, we see lots of patients that have repeated end range of movement activities, explosive activities, and these patients can develop problems within the hip and causing pain. Dancers always are working for getting that extra degree of external rotation, and again can present with pain in the hip because they are trying to force their hip to do things that perhaps it is not designed to do. Yoga, so yoga is great, particularly in terms of core stability in helping patients with hip pain. But again, you kind of have that one end of the spectrum of the militant yogis trying to work on those extra degrees and really pushing bony anatomy that's not allowing them to get that extra range of movement. Rowing, so quite frequently see patients that either row competitively or in the gym, and it's that deep squat in the catch that really can cause some impingement and some pain. And again, powerlifting. So deep squats is one of the activities that you get is a risk position for the hip. Patients can have trauma, so they can have a fall and a twisting movement that can cause pain. Patients can have more significant trauma, so acetabular fractures or a native hip dislocation, which is then reduced, can then have problems with their hip later on. And then patients that are hypermobile, so an increased Baton score, and it doesn't have to be that high, looking at 4+, have increased range of movement in their hip. And this can then mean that the hip can impinge and the structures around it can become damaged. And then at that other end of the young adult hip spectrum, you have overcoverage in how we've discussed in terms of femoroacetabular impingement, but you can also have a dysplastic hip. So the shallow hip joint, the DDH in the pediatric community that was kind of borderline and didn't get picked up perhaps in screening, can present in later life because the hip doesn't have the normal restraints and therefore the function is altered. And that can then lead on to pain. So here's my movie that I've constructed. So here we've got a normal hip joint, okay? And the rotation within the hip joint goes around the center of the femoral head and everything's fine. The blue's the labrum. Here we've got a cam, so highlighted in the red. And as we come up into flexion, that cam starts to impinge onto the acetabular rim, pinching the labrum, which then gets entrapped, and it gets converted into a shearing force at the chondrolabral junction, and that can then drive early osteoarthritis cartilage damage. Pincer lesion here, again, we're showing the overcoverage is now impacting on the femoral head-neck junction, and you get damage to the labrum and then onto the articular cartilage. And then the best or worst of both worlds, when you've got a combined pincer and cam. So now the blue area is to try and represent a normal capsule, and the red line is the ligamentum teres. So the blue is now expanded, so you've got a hypermobile joint. And what happens is that as the hip gets to its end range, its normal constraint of the capsule doesn't stop it, and the ligament gets stretched and can tear. With a cam in this picture, what you're getting is the center of rotation is occurring at the impingement site, not at the center of the femoral head. It pivots just like in the pincer as well, and you can tear the ligamentum teres. Ligamentum teres tears, I think, are a lot more frequent than what we've kind of thought to believe in the past, and it's a fairly frequent presentation of someone who's perhaps had femoroacetabular impingement, has been treated, but some of their symptoms, particularly in the groin, with the pain radiating into the buttock or down the inner thigh, if they've got that type of pain that persists, quite often it's a ligamentum teres tear that's not been addressed, because the ligamentum teres is deep down in the hip joint and pretty difficult to get to. Okay, so in terms of investigations, an AP pelvis is my recommendation of choice, but that has to be taken with a grain of salt. You have to be pretty specific in terms of your request, because the vast majority of radiologists that are reporting plain pelvic x-rays will not necessarily be looking for the detail that is required to interpret an AP pelvis. And particularly for the GPs in the community that aren't able to even look at the images themselves, the report is so important for you. But the reports are very variable, even within the radiology department in the units that I've worked in. You get a very varied interpretation of what is a cam lesion, what's not, what's a pincer lesion, what's not. So I think it is a first line investigation that should be done, and it should be done in the community. But probably the main reason to do it is to rule out osteoarthritis, because if they've got osteoarthritis, then the pathway for treating these patients is going to be different. And sorry, the animations are a bit out of sync there, but in terms of subtle signs, as we've already gone through, there are things that are fairly subtle to pick up that if you're not looking for specifically, it's unlikely that, that they'll be found. So there we go, to rule out osteoarthritis. And the next image that I think is most useful in the young hip population is a modified Dunn lateral. And essentially that is an X-ray with the hip flexed, abducted, and the X-ray beam is being, or the X-ray beam then shows you the anterior neck, and it's the anterior head-neck junction where the vast majority of CAM lesions are. So it's very useful and much more sensitive in picking up femoroacetabular impingement than a cross-table lateral. If you are investigating these patients in the community, you're probably going to get all three, because the cross-table lateral is the one that the arthroplasty guys and girls are more interested in. So here's a plain X-ray. On the left of your screen is an AP pelvis. The right of your screen is the modified Dunn. And this is a bit of an extreme case. And, you know, I would hope that the vast majority of radiologists and orthopedic surgeons in the world would pick this up. But what you've got here is a bony excess bone, a bony bump on the femoral head neck junction, okay? And this is quite a severe case. There's already some sclerosis within the joint, perhaps some joint space narrowing. On the modified Dunn view, so this is the anterior neck. You can tell that because the left trochanter is posterior, okay? So this is the anterior neck. And as you're coming round the ball of the femoral head, you would expect it to go in like it does across here. See how it dips in? Well, as I come around here, it doesn't dip in. If anything, it's coming out, okay? And this is a classic picture of a CAM lesion. And as you can imagine, as this patient flexes up their hip, this bump is going to impact on the acetabulum and cause damage. On the other side of the scale, here we've got someone who's got hip dysplasia. And if you look on the left hip, okay, they've got reasonable coverage of the femoral head. Sourcil angle, this is basically means the roof of the acetabulum is pretty horizontal. Whereas on this side, much less of the femoral head is covered. The socket is more shallow, and this angle here is steeper. Now, again, you know, I would never expect anyone to be drawing lines and commenting on angles and things, but a plain AP pelvis can distinguish between a patient who's got osteoarthritis, impingement, or dysplasia. So I think is worthwhile doing. So other investigations, MRI scan. Probably only 5 years ago, we would have been taught that all patients with non-arthritic hip pain should be getting an MRI arthrogram, because that is the most sensitive way of picking up labral tears. And there's been a bit of a move away from that because the quality of MRI scans has improved, and a 3T MRI scan is better than an arthrogram at picking up detail of why a hip may be painful or not. There are certainly some people that will still want an arthrogram, but that is not my practice, and it's becoming less common. So I don't think performing an MR arthrogram in the community is worthwhile, as I don't think it adds much to changing the treatment plans. 3T is much better at picking up injuries to the labrum, subtle articular cartilage thinning, even tears to the ligamentum teres. 1.5, depending on the sequencing and depending on the person who's interpreting it, is less useful than a 3T. And it's my opinion that the soft tissue injuries that occur in patients that have hip pain without osteoarthritis really depend on the bony architecture and are fairly predictable. The thing that makes whether the soft tissue injuries have occurred more likely is actually the duration of symptoms. So if you get a 16-year-old who has groin pain, they are impingement sign positive during examination, they've got a CAM lesion on their plain x-rays that you've ordered, the likelihood is that their labrum is starting to become damaged. That is why their hip is becoming painful. If one was to operate at that time, the likelihood would be that you wouldn't need to do anything to the labrum. You would just treat the impingement area by removing the bony bump. Whereas perhaps someone who's had pain since they're 16, but are presenting after lots of treatments that haven't worked at 36, are much more likely to have the soft tissue injuries that you'd expect. So a labral tear, articular damage around the chondrolabral junction, and early signs of osteoarthritis. So my feeling is that actually the MRI scan is useful in confirming a diagnosis, is useful in ruling out osteoarthritis, but it's not particularly useful for to guide treatment. So yeah, so we're looking at the early signs of osteoarthritis. So particularly subchondral cysts, particularly any osteoarthritis affecting the femoral head, is unlikely that you're going to make much of a difference with hip arthroscopy. And an MRI scan can give you an idea in terms of the orientation and the version of the acetabulum and the femoral neck, and guide whether you needed any further imaging, such as a CT with rotational profile. But these are all things that I think should be happening in secondary or tertiary care. And then injections. So injections I do lots of, but the reason that I do injections is from a diagnostic point of view. So if I see someone who has who's got barn door signs, barn door radiology findings, barn door history, then I don't think performing an injection is going to make a significant difference in terms of their outcome. But if there's any question at all, then I think a diagnostic injection is really important, and doing that injection and then being able to examine that patient after their injection to see how much pain relief they actually get from the local anesthetic that is injected. They certainly can be used in terms of therapy. It is unlikely that, at least in my opinion, it is unlikely that if you've got a patient who has bony morphology that leads on to impingement and they've got an activity that they're going to continue doing that makes their symptoms worse, it's unlikely that a local anesthetic steroid injection is going to make them significantly better for the long term. But what it can be really, really useful for is to get on top of pain and inflammation to then allow the rehabilitation to be focused and to kind of untrain some of their instability and imbalances around the hip to get them back on the right path. So yeah, so that's how I use injections. So physiotherapy is so important in managing soft tissue injuries around the hip and the knee, and it's my belief really that anything that I do as a surgeon is about trying to get someone back on the pathway to rehabilitating. And the role for physiotherapy within the hip is mainly to reduce the irritability. So hips become irritable really easily, and that irritability does not get better easily. It takes focus in terms of the muscular imbalance, core strength and stability, and really focused on getting patients active but not irritating their hip. And I'm not an expert in physiotherapy at all, but the role is vital, and questioning, I think, and looking for answers is vital, and we don't have all the answers, definitely not. So as I mentioned, we're looking to improve stability, core strength. Core stability is so important in terms of the amount of work that the hip is having to do and the stresses and strains in the musculature around the hip. And there are various protocols that have been published. There is the TOD protocol, TOD, out of Hip Arthroscopy Australia, where I did my fellowship, which has been developed to give a guideline. There are also the protocols that were available for the randomized control studies, such as fashion. But these are guidelines, and they need to be adapted to the local patient population and also the individual. But they are available for at least some guidance and some understanding on how to try and help with these patients. And with everything, I think worst case scenario. So a patient, if I see them in clinic and they've got an ACL, and this is outside of my talk, but an ACL tear, or they've got hip impingement, or they've got something else, all the patients in an ideal world should be going to see physiotherapy that day, have a plan in place, and on a path for a rehabilitation or a prehabilitation. Best case scenario, the patients rehabilitate within that program. They make stepwise progress and are able to get back to doing all the things that they want to do, and their pain or their instability is managed by excellent physiotherapy. Worst case scenario, these patients are going into any operative treatment stronger, more stable, and with a better idea in terms of how much engagement they're going to have to give to get better. Because as I said before, anything I do is only about trying to get a patient back on the pathway to rehabilitate and get back to the activities that they think are important to them. So I know a little bit more about the surgical treatment options, and I'm not going to go into detail about this, but probably up to about 5 years ago, we thought that labral tears were the thing that was causing pain in hips, and if we repaired the labrum, then this would take away the source of the pain and all of our patients would get better. And that was not the case. And the main reason that I think that wasn't the case is because a labral tear is a consequence. It's not the cause of someone's pain. People get labral tears because something has happened, and that's either because they have impingement or they've got hypermobility and they've gone through, to their end range and then pushed it further and they've had a tear, they've had a traumatic injury, or they get a labral tear from degeneration. So you have to treat the cause, not the consequence, because if you've got a hip that still impinges, then no amount of sutures is going to keep that tear back where it is or where it should be and let it heal, and patients will continue to have pain. So you've not made them better, and if you're not making people better, then what's the point? So you've got to address the cause. The aim is to try and repair and restore the functional anatomy. And what I mean by that is you can repair a labrum, and that's restoring that patient's anatomy. But they've got anatomy that means that their hip is not functioning correctly. So you've got to address the bony bumps, whether that's a pincer lesion, whether that's a cam lesion, whether it's the dysplasia around the hip that needs to be addressed. And as I've said it already, we're preparing patients to rehabilitate. Now, we've only really talked about femoroacetabular impingement with too little movement or too much movement, but there are a whole variety of other reasons patients can get pain around the hip. and they're in this kind of mystical area that most hip surgeons either aren't interested in or can't be bothered in, because it takes quite a bit of effort to get these patients better, and it takes a lot of buy-in to get these patients better as well. So greater traumatic pain syndrome is one of them. Snapping hips is something else that we see quite often. There are other impingements other than femoroacetabular impingement. You've got subspinous impingement, ischiofemoral impingement, deep gluteal space impingement, impingement within the cotyloid fossa. The list goes on. If there's anything, it probably can impinge. The most important part of this, though, is getting your diagnosis correct, and getting your diagnosis and the patient on board in terms of what's going on and what can be achieved, what might be achieved, and what can't be achieved. So yeah, OP has another cause of hip pain, which has got a high association with patients that have got femoroacetabular impingement. Hey, it might not even be the hip. They might have a sports hernia. They may have an inguinal hernia. It may be coming from the back. So there's a lot of gray area, and diagnosis is difficult. And that's why I use a lot of injections to try and pinpoint exactly what's causing the pain in the patients. And it is so important to take an accurate and focused history for that patient, okay? Because they might not be having pain in their day-to-day life. They might not be waking up in excruciating pain and having to put a pillow between their knees, but they might be unable to go out and do their rowing training for whichever club that they're trying to do, and that may be impacting on their physical health and their mental health as well. So, you know, it's a focused a focused history on what's important to the patient. Examination findings obviously are important, and I mainly use those to confirm my suspicion from the history. If you take every patient that's got a painful hip and you do an impingement test, you know, most patients, you can get them into a position where they have an impingement positive test. So it's about relevant examination and whether that's reproducing the patient's pain. Investigations we've gone through, and after all of this, the diagnosis can still be unclear. And that's why, you know, looking at the pathways for this kind of more this subspecialty that's getting a bit more recognition and understanding of the things that we can and can't treat is so important. And there is, in most hospitals in the region, there is at least one person that has an interest or some training in non-arthritic hip problems. And I am in contact with the vast majority of those, and we have discussions about patients and you know, patients can be sent up to George's. And I'm more than happy to see anybody or be emailed or called about them to try and make the pathways better and try and get a better understanding of how best to treat these patients, particularly in Southwest London. So thank you very much for tuning in just before Christmas. I hope that everyone can have as merry a Christmas as possible. That's how you can get in contact with me if you want to get in contact with me. If you've got any patient specific scans or anything, then markwebber@nhs.net. If you've got an nhs.net account, you can send me stuff to look at, and I'm more than happy to help. So that ends my my talk. I have the PDF that we can go through, but perhaps we could open it up to some questions and some discussion and go through the pathway as we go on.
Thank you very much. That's brilliant. We've got one question so far from Christopher, who's asking, in first contact practitioner clinics, if doing an X-ray view helps speed up the process to get the patient into the right person? Yes, it certainly does. I can't speak for the other hospitals and how they triage, but if we're receiving a referral and one of the hip surgeons are looking at those referrals, then we can triage them to the appropriate
place and look at their imaging. So just off the top of my head, in terms of patients that sometimes we get referred, we may have a young patient that's got avascular necrosis in the hip with established osteoarthritis. Well, that patient would be steered towards one of the arthroplasty surgeons over myself. And the same way, if we have a patient who's perhaps in their 50s and they've got hip and groin pain, but they've got non-arthritic X-rays, then the team push them in my direction. So yes, a plain X-ray should, fingers crossed, hopefully get the patient seen in the right place, admin depending.
And there's a question from Sam. What would confirm diagnosis for hip capsulitis if in first contact practitioner setting and only X-ray is easier as a primary investigation? Yeah, so I mean, it's about
trying to understand the patient, how the patient's symptoms have come on. So you're thinking more of an inflammatory type picture. And it's difficult, and it's easier for me because patients come to me after trying a lot of different things. Capsulitis should settle by itself, or with some physio to help stabilize the joint, but there's not an investigation that's gonna pick that up, and an MRI scan's not even really going to comment on it. So it's about trying to, I suppose, differentiate on your examination and in your history if it is more of a general irritated hip, if that phrase makes any sense, but an irritation of the hip opposed to a specific movement where an anatomical structure is getting stressed.
So we've got a question from Pablo, and I might actually be able to share something which might inform your answer. But the question is, when referring to you, what would you like to see in the letter?
Okay, yeah. So, Badina, are you referring to the kind of checklist that you sent through?
Yeah. Would you like me to share that screen?
Yeah, that'd be great. So this checklist, which is going to come up, is kind of a draft version of what we're looking at to try and make the pathways a little bit. Shall I stop sharing mine? That might work.
I think I might be able to. You can let me know if you guys can see it. Yep,
there we are. So so this is a draft version of the kind of information that that we think will help hopefully get patients seen to the right places. And again, there are questions in there which are going to be more or less relevant depending on the patients, but is a little bit of a guideline, I guess, in terms of have you thought about this? Have you tried this? Obviously, there are patients, if you just give them a course of non-steroidals, their pain gets better, and therefore they're not going to need being seen. But I don't think that you necessarily you have to say you must have had a course of analgesia. Or, I personally don't think it's particularly appropriate if you have a 17 or 18-year-old that's, trying to play at a top level football club or rugby club or whatever it is, and telling them that they can't do that because, this is about a quality of life thing. This isn't life or death. So telling every 18-year-old not to do the things that they want to do is probably less important versus someone who's 50 and perhaps not still trying to play for England.
So,
yeah, go for it.
If I can just add something to that. So this kind of is just a bit of a summary of looking at the GIRFT criteria for standards of referral. So that's your getting it right first time, as well as your evidence-based interventions, and just kind of putting it all together in one place. So it looks at sort of the symptoms and what effect is this having on the patient's quality of life. It looks at the details of any previous treatment that the patient's had, which is useful when you're wanting to triage or indeed making your decisions of what you might do. There are some general details as well in terms of BMI, weight loss advice, smoking cessation advice, if that's relevant. And then there are sort of your subspecialty special questions that will differ depending on what you're referring for. So the subspecialty special questions listed in the EBI criteria are to do with sort of a positive impingement sign, which is what you spoke about in your talk, as well as has the patient engaged with conservative management? Is there sort of confirmation on radiological investigations like your CAM and pincer that you were talking about? And how is this affecting the patient's quality of life? But also one of the very important things is the shared decision making. So has the conversation been had with the patient that should this lead to a surgery, would that be something, or an intervention, would that be something that they would like? And if they wouldn't, then maybe we need to think of something else for them.
Yeah, and I mean that's got to be the most important thing on there, right? So I don't tend to see many patients that come to clinic and then if they're appropriate for an operation, turn it down. But that's mainly because I think it takes quite a while to come and see me. So most people have already tried the vast majority of the non-operative things, and you know this Proforma is reasonable to be using for femoroacetabular impingement, but there's lots of other reasons that patients can have pain in the hip. So it should just, I think, just be a guide. And there are limitations. GIRFT has got limitations because you are you know, to tick the right box, you've got to have radiographic signs. Well, you know, that's variable in terms of whether you're going to get that information in the community or not. So, you know, I think it's really good to get an idea in terms of the things that you can try, but don't limit at least asking the question.
No, and it's just about having as much information as you have. So if you don't have some of this information, then it doesn't mean that you can't refer.
Exactly.
And then from Christopher, some clinics are doing hip joint injections. Would that be worth doing as part of the diagnostic process, or is that better to be done by someone like yourself? I don't know if that means sort of intra-articular hip injections versus something like a trochanteric bursitis or...
Yeah, so I mean, so, you know, a painful trochanteric I think is reasonable to be doing in a clinic if you've got ultrasound and you're confident doing those injections. Even if it is just a diagnostic point of view, makes their pain better for a couple of hours, but then it comes back, or it enables them to then commence, you know, good rehab program that they're able to then get better hip stability. In terms of intra-articular injections, I think it depends on what your purpose is for. I don't think we should be injecting joints because we can, just, you know, because, oh, we can inject your joint and we'll see how it feels. I think it's important to understand why you're doing the injection. So if it is to reduce irritability to then enable someone to rehabilitate, then I think that is a reasonable injection to do. If it's to do an injection to get a diagnosis to then refer on, I think it's probably less useful, because there are a variety of different skill sets and different people and different ways of injecting and what's injected, that actually by the time the patient comes to see someone like myself, they are fine. Well, I've not had anyone that comes and says, oh yeah, no, my hip pain was better for the 3.5 hours that the local worked, and then it came back, which is a great positive diagnosis injection. But patients tend to forget about that by the time they've come. So I think doing diagnostic injections, intra-articular diagnostic injections, are less useful, because they're probably just going to get repeated.
And Pablo's asking about, so a frozen shoulder exists, does a frozen hip exist? Yeah,
great question. I've not seen one, but I see no reason why in theory it shouldn't. But the difference is, I think, in terms of what a hip always has to do. So you don't necessarily, it's very difficult to protect your hip even if it is painful and you do have inflammation within the hip joint. You have to walk around and you have to keep it moving, whereas shoulders can be held in a position of comfort, which then allow, you can then move on in terms of stiffness. I've not seen one. If someone sees one, let me know. It'd be interesting.
And then the last question I can see so far is, can you please share the pathway for the SUFI pathway?
Yeah, okay. I mean, so I don't have one available just to pop up, but in terms of the pediatric orthopedic surgeons, you're looking at that adolescent group, so kind of 10 to 16 as you of patients who get groin pain or knee pain. Don't forget knee pain. It's quite common that patients, can have knee pain for quite some time, and it's actually their hip that's causing the problem. So that kind of rapid growth stage in life, onset of pain, difficulty weight bearing, to the point that you're kind of thinking, do they have a septic joint, but they're not sick? So maybe it's just a groin strain. Let's see. These patients should get an early X-ray, and the way that we would accept that at St George's would be that a referral from normally from the GP would come in to the on-call team. The patient would come to the emergency department and get an X-ray. The pediopods may have a more streamlined way of that's in place, but those are the patients to be thinking about, particularly if they're a little bit overweight, particularly if they are like Afro-Caribbean ethnicity, or if they've got any hormonal problems in their history.
Are there any other questions from anybody? And it's also just worth mentioning that sort of the pathways may be slightly different in Southwest London. So whether the patient lives closer to St George's or Kingston or Croydon or Epsom and St Helier, the patient would essentially, the pathway into their closest acute hospital, and their surgery, depending on what it is, may happen at their base trust or it may happen at SWL. But it's just important to mention that across Southwest London, you would refer the patient exactly on the same pathway as you would now, even though we're all kind of working as one big team. And if there aren't any other questions, thank you very much for joining us so close to Christmas, and also with all of the sort of challenges happening on the ground for everyone at the moment. So we really do appreciate it. And we will send you the link to the recording of the webinar if you'd like to share with your colleagues who haven't managed to join us, and also that feedback form. And then we will be in touch in January with the next ones. There might be one other question. Would you mind sending the referral proforma? Absolutely. This is something that is just, again, a guide. So it's not anything that's published anywhere, or it's just kind of a guide and a summary, but I'm very happy to share. So if you'd like to, or I'll have your email address anyway on the attendees list, so no problem, I will send that. There is another question from Sergio. So a symptomatic patient without mechanical symptoms responding to activity modification, usually patient, and I agree, onward referral to physio. Symptomatic patients, positive on imaging with mechanical symptoms, often we refer to orthopedics with or without rehab. Few patients are not interested in onward referral to orthopedics, they want to wait and see. So what is the likelihood or percentage of these patients who are often physically active to sustain an internal derangement? So I think what I'm taking from that is, if they've got positive imaging, but they don't want an onward referral, what's the likelihood of them?
So it's really interesting, isn't it? So, you've got to keep in mind that there's definitely people in the population that would have positive imaging findings, but never become symptomatic, and they may be doing all the same activities as their brother or their sister or whatever, but never become symptomatic. For patients who've got positive history and examination findings in keeping with femoroacetabular impingement, who become symptomatic, who want to remain active and doing those activities, it is unlikely that their pain will just go away. It may become better, but it will tend to recur once they get back to the activity and the intensities that they've previously done. And, you know, we all love to talk about evidence, and I put my hand up and say that the evidence for non-arthritic hip surgery and physio is actually pretty limited, because we've just not really had much of an idea of what was been going on. But there is evidence to show out of Australia that for patients who had symptoms for greater than 3 months, that were operated on at around about 3 to 6 months, that their findings in terms of labral tears and articular damage was significantly less than the patients who had symptoms and then were operated on a year or greater afterwards. So I can't put my hand on my heart and say, you know, every patient who's got hip pain and positive impingement, your hip's going to wear out, it's going to get worse over the next year, and you're going to need a hip replacement in 5 years. But it seems that if there is a mechanical cause for the pain, that that it's unlikely that it's going to improve if you continue doing the things that you want to do. So it's either stop doing the things that you want to do, or think about having something done about it.
And then a last question that I see from Pablo is, if there is one-sided hip symptoms, do you routinely measure leg length? And if you do, how do you measure it?
So I would not necessarily routinely measure their leg length specifically. I always get people to stand up and put my fingers on their anterior superior iliac spine. I always ask them if they feel anything, but I don't necessarily get a tape measure out and measure from ACES to medial malleolus, which would be my kind of standard way of doing it in the clinic. A lot of the patients now that I see, because we are more aware that rotational profiles got quite a big play in this. So the version of the acetabulum to the version of the femoral neck, we're more keen on getting some further investigations with that. And at St. George's, we've got an EOS scanner, which is basically, it's a low dose CT of patients that are standing. So it's a functional CT in weight bearing, and they can comment on it in terms of the rotational profile, version of the femoral neck and the acetabulum, and they also get a very accurate leg length measure. It's actually less radiation than long leg alignment views that we, were getting up until 6 months ago. So that's kind of a little bit of a cheat answer. I get a fancy test that we can send the patient around for, and they measure it for me.
And then the last one from Sergio: should we request alpha angle measurement routinely?
I don't. So if you're requesting it to kind of to give the radiologist a little bit of a hint in terms of does this patient have a cam, then it can be useful. I don't measure alpha angle routinely. But yeah, I mean, I think in terms of getting a radiologist to look at it, or get them to pass it on to someone who knows why you've asked for it, could be helpful in getting a useful report back for you. There isn't an absolute angle that makes a difference in terms of one treatment to another treatment, but it might just kind of stir the brains of the people looking at the scans in the dark rooms.
There was something extra there, but I'm certain that's probably part of the same thing. So I think that's it for the evening, everyone. Thank you very much. And thank you to Mr. Webb for his brilliant presentation.
Well, thank you for having me.
And Merry Christmas to everybody. I hope you get a little bit of time off over the festive season with your families. Take care, everyone.
Take care. Happy Christmas.
We'll be in touch soon. Bye-bye.